Hi friends, here we are presenting a case of rectal prolapse for which we had done Altemeier'S procedure. This is a 32-year-old female who is a mentally retarded patient, came with rectal prolapse. This is a complete prolapse. We were able to reduce it under anesthesia. We did colonoscopy and MRI defibrillography. After that, once the edema reduced, we proceeded with Altemeier'S procedure. We just did tattooing 2 to 3 centimeters above the dentate line, and we cut the mucosa and serosa, and then we are opening the pouch of Douglas anteriorly, and we are entering into the peritoneum and pulling the redundant rectum, and this is the place of intussusception. You can see it here, and once the redundant rectum is pulled, you can see the mesocolon which is attached, and the mesocolon should be dissected out from the rectum close to the rectum, but we should make sure we are securing the hemostasis perfectly, because once it's retracted it bleeds inside. You should ligate it whenever necessary, and you should dissect with harmony close to the colon. You can see it here. We are using ligation whenever there is a larger vessel, and we are dissecting with harmony closer to the rectum. This is a massive redundant rectum and colon. You can see it here. We are just assessing once it's pulled down, and after that we are just cutting just at the level of anal verge. It should not be too inside. That may cause anesmosis leak, and too distal may cause a little bit of prolapse. So at the level of anal verge, the colon is cut, and at 12 o'clock we are just suturing with the distal end to the proximal end, and the same is done in the 3 o'clock and 9 o'clock with 20 PDS. So you can see it here. 9 o'clock it's already done, and also in 12 o'clock. Now we are doing it in the 3 o'clock. Once these positions is taken, then only we should be cutting the from 3 to 9 o'clock position in the lower part, so that it will not retract inside. That may give us trouble while doing the anastomosis and give more tension of the anastomosis. So once all these 3 sutures are taken, the lower part is cut. Once it's cut all over, the rectosigmoid is taken out. You can see this is a large rectosigmoid which was written, and then in between the 4 stitches we can do suturing with 20 PDS. That can be done continuously or intermittently. Here we are doing continuously with 20 PDS between the all the 4 stitches. So this is the anastomosis. While doing this, we should make sure we are including all the parts of proximal and distal part of bowel, and make sure not to leave the serosa of both the proximal and distal part of bowel. And once it's taken, it's ended with abutting knot. As it is a PDS, it is easy to do. Once the suture is completed, we should make sure if needed some intermittent stitches are taken, and once it's completed, it's pushed inside. You can see it's reduced, and this is the specimen. Postoperatively, patient is doing good. Thank you.